Welcome to The Explainer. Today, we are going to break down everything you need to know about managing common sports injuries. This is specifically for pharmacists, so we're really going to focus on the evidence and, most importantly, the crucial counseling points you'll use every single day. All right, let's set the scene. A patient walks up to your counter. They've twisted an ankle playing basketball, pulled a muscle at the gym. You know the drill. Your advice right then and there is so important. So what's the game plan? Let's build a solid, evidence-based framework for exactly how to handle that conversation, starting with the big picture. So, first things first, before we jump into specific drugs or treatments, we have to be super clear on what we're actually trying to accomplish. What does a win look like for this patient? Look, it's not just about getting the pain to stop. That's part of it, for sure, but the real goal is a full, functional recovery. We're talking about reducing that initial pain and swelling, yeah, but also getting them back to normal, restoring their strength and flexibility, fixing any underlying issues that might have contributed, and finally, getting them back to their sport or activity safely. Okay, so where do we start? Well, before you even think about reaching for a bottle on the shelf, the absolute foundation of care is non-pharmacologic. It's simple, it's effective, and honestly, it should be the very first thing you talk about with any patient who comes in with an acute injury. And you know it well, rice. But let's quickly break down the why for our patients. Rest isn't about sitting on the couch for a week, it's about resting the injured part, but then moving it as soon as it's feasible because that actually helps it heal. Ice is all about tackling that initial pain and swelling in the first 48 hours. Compression with a simple elastic bandage gives support and keeps swelling down. And elevation? That's just using gravity to our advantage. This is your first line advice every single time. All right, once that rice foundation is in place, we can start talking about managing the pain and inflammation. And that, of course, brings us to probably the most common choice, NSAIDs. Now, here's a huge counseling point: oral versus topical. It is not a one-size-fits-all deal. For a young, healthy person with a sprain, a short course of an oral NSAID is probably fine. But for an elderly patient or anyone with a history of GI problems, kidney issues, or heart disease, you're going to want to lean heavily towards a topical NSAID. You get that localized effect right where it's needed without all the systemic risks. It's a much, much safer choice for them. So this right here is your essential NSAID counseling checklist. Number 1, stress that this is for short-term use only. This isn't a long-term solution. For your older patients, maybe even start with acetaminophen. If you do need an NSAID, go topical. And you absolutely have to counsel on the risks, things like stomach upset, GI bleeding, kidney function, and blood pressure. Even a simple tip like take this with food can make a world of difference. So what happens when the injury is more chronic, or it's just not getting better with the basics? Well, that's when we start to look at some more advanced options. And let me tell you, each of these comes with its own very specific and very important counseling points. When you get to this next tier of treatments, it's all about managing expectations and ensuring safety. With corticosteroid shots, yeah, they can provide some great short-term relief, but you have to be honest with the patient that the long-term benefit is kind of questionable. With something like a nitroglycerin patch, the counseling is all about safety. And for platelet-rich plasma, or PRP, we need to be upfront that the jury is still out of it. The evidence is still growing. Okay, this is a huge one. A critical safety alert you cannot forget. While those steroid injections can be useful in some areas, like a shoulder, they are a big no-no for the Achilles tendon and the patellar tendon. Why? Because the steroid can actually weaken the tendon tissue, putting the patient at a much higher risk of a complete rupture. That is a catastrophic outcome we have to help them avoid. Let's really drill down on the nitroglycerin patch because your counseling here is vital. First, the dose. They're often using just a piece of a patch. Next, side effects. Warn them that headaches are super common. They need to know that's expected. Also, be aware of dizziness. But the absolute, non-negotiable red flag counseling point is the contraindication with PDE5 inhibitors like sildenafil. That combination is a recipe for a dangerous drop in blood pressure. It is absolutely contraindicated. Okay, let's shift gears and focus on two special populations where our advice on medication safety is just paramount. I'm talking about patients who are pregnant or breastfeeding. So here's the bottom line. NSAIDs need to be avoided in the 3rd trimester of pregnancy. The big risk here is that they can cause a vital blood vessel in the fetus, the ductus arteriosus, to close prematurely, and that can lead to some really serious complications. So for these patients, there's a really clear hierarchy. Your go-to first choice analgesic is always acetaminophen. Simple as that. Now, NSAIDs are generally okay during breastfeeding, but that third trimester warning is firm. And it's also worth noting there's a caution for use between 20 and 30 weeks because of potential effects on the baby's kidneys. Getting these details right is how we ensure both mom and baby stay safe. All right, let's bring it all home. We've covered a lot of ground, so let's boil it all down into a final, super actionable checklist that you can have in your back pocket for your next patient encounter. So if you remember nothing else from this explainer, remember these 5 points. 1. Always start with ice for acute injuries. 2. For elderly patients or those with GI or heart risks, go with topical NSAIDs. 3. The nitroglycerin patch and PDE5 inhibitors, a huge no. 4. Know the tendon rupture risk with steroid shots in the Achilles or patellar tendons. And 5. For pregnant patients, acetaminophen is number 1, and no NSAIDs in that third trimester. These points are really the cornerstones of safe and effective care. What we've talked about today is a really solid foundation based on the evidence we have right now. But this field is always changing. As new therapies pop up and the data on things like PRP gets clearer, our role as pharmacists is just going to keep growing and evolving. And that's exactly why staying on top of this stuff is so incredibly important. Thanks for tuning in.